Hello, and welcome to today's episode of the VJHemOnc podcast. We recently attended the 18th International Conference on Malignant Lymphoma in Lugano, Switzerland, where we caught up with leading experts from around the world to discuss the latest advances in disease biology, clinical management, and emerging therapies in lymphoma. One of the topics of discussion at this year's meeting was the management of central nervous system lymphoma, a rare and aggressive form of non-Hodgkin lymphoma that remains challenging to treat. In today's episode, we'll hear from two clinicians who are helping shape the landscape of CNS lymphoma care. First, we're joined by Dr. Kathryn Tringale, who shares her perspectives on consolidation therapy in primary CNS lymphoma, the key clinical challenges, and practical advice for oncologists. Later, we'll be joined by Dr. Nikita Dave, who focuses on secondary CNS lymphoma and discusses the promise of bispecific antibodies, CAR T-cell therapy, and evolving treatment strategies. Dr. Tringale, thank you so much for joining us on the podcast today. At this year's ICML, you presented on consolidation strategies following methotrexate-based induction in primary CNS lymphoma. To start us off, can you walk us through some of the key takeaways from your talk?
The treatment paradigm for primary CNS lymphoma includes an induction with high-dose methotrexate-containing regimens, and then that's typically followed by consolidation in patients who have a response to induction. I put all this together for ICML, so I've looked at all the data. There's lots of prospective data really comparing these different consolidation regimens, and it boils down to autologous stem cell transplantation, whole brain radiation therapy with non-myeloablative chemotherapy, or non-myeloablative chemotherapy without the radiation. And when we look at the prospective data over the years, autologous stem cell transplant has been shown to be better than doing non-myeloablative chemotherapy in terms of more durable control. When you compare it to whole brain radiation, and as a radiation oncologist, I really want to specify that we're talking about what I'll call standard dose whole brain radiation, which means doses higher than 30 gray. So typically closer to the order of 40 gray. We see that depending on which study you looked at, it looks like stem cell transplant likely has more durable control than whole brain radiation at standard doses, but the toxicity profile is a little bit different. And some studies have shown similar survivals, but really just durable control with transplant. But the toxicities are really where they differ. And so for transplant, we do see a handful of transplant-associated mortalities. And so patients, typically, we think about them needing to be fit, younger. And then with standard dose whole brain radiation, the concern is really neurotoxicity. So based on clinical outcomes and also looking at MRIs, we see greater neurotoxicity with standard dose whole brain. So as a radiation oncologist, I wanted to specify that dose because I'm excited about this shift towards reduced dose whole brain radiation, which is more on the order of 23.4, 24 gray. So almost half of what historically had been used. There's a prospective RTOG trial. The prelim data was published a few years ago back at ASCO in 2020 that showed very promising results with no increased neurotoxicity with reduced dose whole brain compared to non-myeloablative chemotherapy alone, and showed better progression-free survival. So what I did with my group at Sloan Kettering is we actually looked at a huge cohort of patients who had from the 80s until now, basically, to compare these different consolidation regimens. And this was published in Blood Advances last year. And what we saw was, first of all, any consolidation is better than none. So that's important to know. When you account for all clinical demographic variables, there's no significant difference in progression-free overall survival with these different consolidation regimens, which I think just speaks to the fact that it's all about patient selection. So for fitter patients, again, younger or fitter older patients, really transplant seems to have some of the best durable control over time. But then, right next to it, we have reduced dose whole brain radiation. And while this is retrospective data, there are no prospective trials comparing this reduced dose whole brain to transplant. So I think that this study that we did really encourages us to think about using reduced dose whole brain radiation in patients who cannot get transplant. So we basically support that prospective RTOG data showing that reduced dose whole brain likely is preferred to non-myeloablative chemotherapy.
That's great. Thanks so much for sharing your study. From your experience, what are some of the most difficult aspects of treating these patients, and what advice would you offer to community oncologists who may encounter these cases?
I think it's a great question because I do think it's a very nuanced and challenging disease to treat. And when I say disease, I mean it's a host of diseases. So I think first I alluded to when talking about the different consolidation regimens, it's all about patient selection. So really understanding your patient and the toxicity profiles and risk factors before making a selection for consolidation regimens and even induction, what you think the patient can tolerate. So one, I think is important to think about patient selection. Two, it's all about multidisciplinary collaboration, which I think is, a blessing and can make things more challenging too. So you really have to collaborate. And so when I'm thinking about these patients who are seen by community oncologists, you may or may not have access to a blood and marrow transplant team. And so I think my recommendation stems from our work looking at different consolidation regimens is if patients are ineligible for transplant, you don't think your patient's the right patient for a transplant, or you don't have access to a transplant, I would really consider using this reduced dose whole brain radiation as opposed to just non-myeloablative chemotherapy for some of these patients. And then I think finally, another challenge, again, as a radiation oncologist is not debunking the myth of neurotoxicity, because I do think that's based on years of data showing that these higher doses of whole brain radiation can be neurotoxic, although they can be a great disease control approach. I think the challenge has been really just informing everyone that there's different doses with different outcomes and different toxicity profiles. So I think that we really need to consider reduced dose as a totally separate approach than standard dose whole brain when we're talking about consolidation. At Sloan Kettering, we also combined all of our data. This was published last year in the Red Journal, looking at cerebral atrophy over time after different consolidation regimens. And we actually showed that all primary CNS lymphoma patients after induction basically have cerebral atrophy over time compared to the normal population as they age. So we know that they have cerebral atrophy. I think a huge part of this is the high-dose methotrexate. But our main finding was really that rate of change over time did not differ by consolidation regimen. So it was similar between transplant patients and reduced-dose whole brain radiation patients. So final one I think is a challenge is thinking about neurotoxicity. And I'd like to remind community oncologists to consider reduced-dose whole brain radiation as a safe and effective approach for patients.
Wonderful. And given the complexities involved, are there any particular strategies, guidelines, or recommendations that you think are essential for community practitioners to be aware of?
I think this is a great question because it is a host of diseases. So first we have primary CNS lymphoma, so disease really in the central nervous system and confined to the central nervous system. And then we're having, in our world as radiation oncologists, we're seeing this more and more, especially on call, secondary CNS lymphomas, so extracranial lymphomas that then spread to the central nervous system. And I should say even beyond lymphomas, I mean, we think about this in leukemia, we think about this in myeloma, and we're seeing the CNS as a sanctuary site for these diseases to spread as all our novel therapies continue to improve and patients live longer. We're seeing this disease spread to the brain and the spinal canal. So I would say that secondary CNS lymphoma is something I'm also very interested in. Again, we're seeing it more in the urgent and emergent setting. And so I was speaking with my good friend Susie Hineker at Stanford and Dana Casey at University of North Carolina. We're saying, we're seeing more and more of these patients. What are you guys doing over there? What are you guys doing? And so we put our heads together and we got a group of experts, so from Stanford, UNC, Sloan Kettering, at UCSD, and we put together guidelines. So I'd like everyone to be aware of the guidelines that we wrote for urgent and emergent use of radiation for secondary CNS hematologic malignancies. It was published in Frontiers in Oncology earlier this year. And what we do is we go through histology specific and disease compartment specific, meaning is it in the brain parenchyma, the vitreous, is it in the spinal fluid, do they have gross radiographic leptomeningeal disease? So we go through these different clinical scenarios and we provide dosing guidelines as well as treatment volume guidelines in terms of, are we treating focally just to the site of disease, or do we need to treat the whole brain or craniospinal axis? So we come through and provide a table to basically guide you through answering some of those questions. I think the most important thing that I want to take everyone to take home from that paper is that radiation is an effective and very fast-acting tool for hematologic malignancies. And while systemic therapy can also be very fast-acting and very effective, for some of these patients we're seeing on call, some of them vision changes. I just had someone last week, acute visual changes, neurologic deficits, paralysis. And patients are coming in with these new onset, urgent and emergent symptoms that are neurologic. Often early radiation can resolve some of these symptoms. So I really encourage my colleagues out in the community to really consider radiation early on for these patients to help improve and prevent further worsening of neurologic compromise. Even if your systemic therapy colleagues, your medical oncology colleagues really want to start with systemic therapy, which I don't necessarily think is the wrong thing to do, we talk about it in the guidelines, even simulating your patient early on to get a scan and get a plan ready to go, just in case the systemic therapy doesn't work as quickly as you want it to, so you have it as a backup. So I recommend looking into those Frontiers in Oncology guidelines.
Finally, looking ahead, what are some of the most promising areas of research in primary CNS lymphoma? Are there any novel approaches that you believe hold particular potential?
I think this is definitely an area ripe for research. There are many ways that we can come at this to improve outcomes and reduce toxicity, which is always our goal in this disease. For further reducing toxicity, there's several studies going on to optimize induction regimens. We talk a lot about consolidation regimens and how to select the best consolidation regimen. But as I mentioned, our data showed that even after just the induction regimen, people have some neurotoxicity. So how can we optimize an induction? I'm also excited that there's more work going into optimizing the conditioning regimen for autologous stem cell transplant so that more patients can be eligible for transplant. So I think that's all exciting. Novel therapeutics, we know CAR T-cell therapy, that's been evaluated in CNS lymphoma in the relapse refractory setting. BTK inhibitors are very exciting and used in relapse refractory and starting to get used more in the upfront, maintenance therapy setting. All of that is very exciting. I think as a radiation oncologist, my number one goal is how can we get patients to these novel therapies? A lot of the trials say, if you have a complete response to induction or you're in a complete response, then you can have this other therapy. But there are a lot of patients who aren't in a complete response, who have some element of residual disease. So how do we get patients to those new therapies? I'm very excited to use radiation. We don't have to necessarily think of it as whole brain radiation, big volumes, big doses. Now in the new era, if we're bridging you to some other therapy that's very exciting and can take care of that microscopic disease, is it safe and effective to use focused radiation just to the site of disease and bridge you and get you on to that new therapeutic? So I think that's the most exciting area that we really need to get more data on to understand safety and efficacy there. Because I think from my own experience and talking to my colleagues, a lot of us are starting to do this now. I'm spearheading with Dr. Brandon Imber at Sloan Kettering. We're spearheading multi-institutional efforts really to put all of our data together. Because again, this is a very hodgepodge group of patients with different histologies, different presentations. And so it's hard to come up to conclusions with just small numbers for each scenario. But if we put our heads together, which we're doing through the International Lymphoma Radiation Oncology group, the ILROG group, we're putting our heads together and we actually have a multi-institutional effort now to combine all of our data on radiation for secondary CNS lymphoma so that we can start to understand our current patterns of utilization of radiation, doses, volumes, indications, put all that together so we can come up with some clear guidelines and prospective trials that we can use, I think, to incorporate radiation in the new era.
Thank you so much for sharing your insights, Dr. Tringale. Now, let's turn to Dr. Nikita Dave, who also joined us at ICML 2025. Dr. Dave focuses on secondary CNS lymphoma, which occurs when lymphoma spreads to the central nervous system concurrently with or following treatment for systemic lymphoma. In our conversation, she explores the role of immunotherapy in this setting and compares the management of primary and secondary disease. Dr. Dave, it's a pleasure to have you with us. To begin, could you tell us about the clinical outcomes you've seen with bispecific antibodies in secondary CNS lymphoma?
Yeah, so I'm really excited about bispecifics in CNS lymphoma. As you probably know, they were approved in 2023 for systemic lymphoma, in particular glofitamab, epcoritamab, and mosunetuzumab. And there have been pretty good responses so far, but the initial trials unfortunately excluded patients with CNS lymphoma. You can imagine glofitamab, for example, is quite a big antibody. It actually has two FC regions, and it's about 250 kilodaltons. So there were some concerns that it wouldn't in particular penetrate the CSF. So they actually excluded these patients. So we didn't know whether or not bispecifics penetrated the CSF. There was a really interesting paper in the summer of last year from City of Hope, where they actually looked at 4 patients who got glofitamab for secondary CNS lymphoma, and they found that glofitamab actually did penetrate the CNS. So that paper was really exciting. And actually, ever since that paper, we did have about 10 patients that we treated with glofitamab in particular for secondary CNS lymphoma. And we wrote those patients up for this particular conference. And what we found was that there were actually pretty good responses. Response rates were about 80% in the CNS in particular. There were low rates of toxicity. You sort of worry about cytokine release syndrome and neurotoxicity in particular, but those rates were pretty low. The follow-up, unfortunately, has been pretty short, and this is a pretty new therapy for these patients. So I'm really excited to see what comes of this in the future. I think this needs to be done prospectively, however. Our study was retrospective, but it's still really exciting because the median overall survival of secondary CNS lymphoma we know is about 5 months. It's actually, I would argue, one of the most aggressive B-cell lymphomas. So it's really exciting to have any therapies that really can prolong patients' lives when they have this really aggressive disease.
And what about CAR T-cell therapy? What do the current data suggest about its safety and efficacy in patients with CNS involvement?
CAR T-cells are really exciting. They've definitely been a focus of a lot of this conference because they provide a really interesting and efficient option for patients with systemic lymphoma in particular. Similar to bispecifics, there were initial questions as to whether or not the T-cells can effectively traffic and penetrate the CSF. So the initial trials actually also excluded patients with CNS lymphoma. But more recently, there have been data showing that actually CAR T-cells do in fact penetrate the CSF. So we had about 20 patients who got CAR T-cells with active secondary CNS lymphoma. And what we really found was that, unfortunately, CAR T-cells do not provide a long-term remission for these patients. We know that in patients with systemic lymphoma, CAR T-cells, in particular DLBCL, CAR T-cells can induce a long-term remission in maybe about 40% of patients. But in our particular study for secondary CNS lymphoma, that number was about 10%. So it did not yield a long-term response. And the rates of ICANS, in particular high-grade ICANS, so grade 3 and 4, were pretty high. So several patients had seizures, complications, probably due to the off-target effects of CD19. So I think, in comparing CAR T versus bispecifics, I think bispecifics are pretty interesting and neat in that they don't have as much toxicity and that they didn't have a lot of CRS and ICANS. And the duration of response was about 5 to 6 times longer than CAR T cells. So I think that there's still some work that needs to be done with CAR T cells in terms of, how they penetrate the CNS. Are there other agents we can give along with CAR T to make them more efficacious in the CNS? It's possible. But I think for now, bispecifics, for me in particular, are really exciting as a new therapeutic option.
You also presented a poster at ICML this year on a prolonged regimen of methotrexate, temozolomide, and rituximab for secondary CNS lymphoma. Could you walk us through the rationale and findings from that work?
So this is a little bit different from CAR T and bispecifics in that this is a chemotherapy option, right? Bispecifics and CAR T are totally chemo-free. But, up until more recently, chemotherapy and radiation were really all we had for a secondary CNS lymphoma. And there's a lot of controversies as to what exactly is the best chemotherapy option for these patients. There's really no standard of care because, as I mentioned, in a lot of these trials, patients tend to be excluded. So every institution, every country does something a little bit differently. And at Penn, we do something sort of unique in that we use this particular chemotherapy option called MTR or methotrexate, temozolomide, rituximab. And this is based off of the Alliance 51101 trial, which was published in the summer of last year. So we use these 3 chemotherapy agents. We give it initially every 2 weeks and then space it out to monthly for induction. And then for maintenance, as a consolidation, we do a monthly maintenance to complete a year of therapy. It's a pretty unique regimen. We actually just published a paper in Blood Neoplasia just last week with this particular regimen in primary CNS lymphoma. So we wanted to look in particular at our patients with secondary CNS lymphoma, since we know the outcomes are so much worse. And as I mentioned, the median overall survival generally of secondary CNS lymphoma is about 5 months. But with this particular regimen that we used, the median overall survival was about 7 years. So it was pretty effective. It's a small cohort of patients, but we know that the regimen is not very toxic. Oftentimes, these patients are pretty beat up from a lot of the systemic therapies that they've already gotten for their systemic lymphoma. So it's very hard to give them even more aggressive chemotherapy for their CNS lymphoma. So I think in general, managing and balancing toxicity and efficacy is really important. So I think this regimen is pretty efficacious, and, no patients really needed to discontinue therapy for toxicity. No patients died from therapy. That's really important to mention. So I'm really excited that we got to look at these patients and that their outcomes were in a span of years as opposed to a span of months.
Finally, could you help clarify the key differences in managing primary versus secondary CNS lymphoma? How do the treatment goals shift between these two settings? And what should clinicians keep in mind?
I think about primary and secondary CNS lymphoma really differently, in that the prognosis is really different. With primary CNS lymphoma, the median overall survival can be in a matter of 10 years versus I've been mentioning with secondary CNS lymphoma, it's much lower. So when I think about how we manage primary CNS lymphoma, I think we need to balance efficacy and toxicity, as I had mentioned earlier, because we know that these patients are going to live for a long time. And similar to secondary CNS lymphoma, there's really no standard of care for how we manage primary CNS lymphoma. I think here in Europe, they go based off of the ILSEG 32 trial, which was published back in 2016, that typically involves matrix, followed by an autologous stem cell transplant with thiotepa and carmustine conditioning. That's sort of, I think, I would say maybe the standard of care here in Europe, but at least at our institution at the University of Pennsylvania, we've seen a lot of toxicity with some of these therapies. So we tend to use a gentler regimen based off of the Alliance 51101 trial. So this is, again, MTR given every 2 weeks and then spaced to monthly for induction. And then for consolidation, additional 6 months of therapy. And we found that patients tend to do really well. And again, the toxicity is pretty low. So I think that it's just really important that we, as I mentioned, just manage toxicity and manage efficacy, and MTR is really important for that. For secondary CNS lymphoma, what I think about here is that oftentimes it's really important to think about the patient's systemic disease as well as their CNS disease. So it can be really hard to manage these patients because they're so heterogeneous. So I think in terms of how we think about these two patient populations, it's really different, but it's nice to have some therapies that we could use in both populations. And I'm really excited about all the work that we published in both spaces.
Thank you so much, Dr. Dave, for sharing your experience and perspective. That brings us to the end of today's episode. Thank you for listening. We hope you found these expert insights valuable. If you enjoyed this discussion, be sure to follow us on X at VJHemOnc. And subscribe to the VJHemOnc podcast on Spotify, Apple Podcasts, or Podbean so you don't miss future episodes. And head over to VJHemOnc.com to see our full coverage from ICML 2025. Until next time!